This is Roadmap to Resilience, an audio series for professionals and families who are supporting children experiencing stress and trauma. I'm Dr. Julian Ford.
And I'm Dr. Amanda Zelahusky. Whether you work with children or you have children of your own, this podcast is for you.
So in this episode, we're going to talk about how the training programs that prepare for professionals to provide healthcare, mental health care, behavioral health care, child welfare services, social work services, a whole range of professional careers in which we can actually help children and families recover from trauma. How those training programs address the impact of trauma, exactly what we've been talking about in this series. For many of us, it's still surprising how little is actually addressed around the issues of the impact of trauma on children and families in our training programs. This is changing. It's growing, and it's becoming much more widely recognized that we can't really teach people how to provide healthcare or mental health services or social work services or nursing services without addressing the impact that for many of their clients and patients, trauma has played in their lives. So in this episode, we're going to talk about, and we're going to hear from some experts who know about the training programs and how we can provide a trauma-informed approach within training programs in a way that is not burdening for the programs or for the learners, but that expands their field of vision so they recognize that the roadmap to resilience from trauma is a crucial part of what every healthcare provider is delivering when they're caring for children and for families.
Yeah, you're going to hear from lots of different experts with different specialties and experiences because we really think it's important for there to be this cross-disciplinary collaboration in our training context. And so, especially as we're all trying to figure out the best ways to care for clients and patients and help them to build their resilience.
So one of the first things that's important to know is where are their resources? Before we talk about the training programs, where are the resources that any of us can tap into and that are especially important for people who are in training or who are acquiring continuing education so that they are really prepared to provide trauma-informed services? And a number of organizations that the commentators in this series, and Amanda and I as well as co-hosts, have been privileged to participate in, provide some wonderful resources. I'd start with the National Child Traumatic Stress Network, which has just a plethora of resources on how trauma impacts children, how children recover, the kinds of services that are evidence-based, the ways in which programs can be trauma-informed. And that's a great starting point across a wide variety of types of traumas that children experience. But beyond that, there are some amazing resources for children and families on the websites of the American Professional Society on the Abuse of Children, APSAC. And you'll hear from some members of that organization. There are also resources from the International Society for Traumatic Stress Studies, and you'll hear from some of those experts as well. And the International Society for the Study of Trauma and Dissociation, yet another international organization that provides some remarkable resources to help us understand how trauma impacts children and families and how recovery and resilience are possible. And I don't want to leave out the American Psychological Association and its Division 56, which is the Division of Trauma Psychology. Again, some of our commentators are members of that organization as well, and it has some remarkable resources.
And one of the things I remember starting out as an instructor and providing, mentoring and supervision to students in some of these different types of clinical programs is not really knowing what is at the crux of training students and interns in trauma-informed care. And so I just really want to underscore all those organizations that Julian just mentioned, because many of them have websites packed with resources that lay out things like core competencies in trauma-informed care and what that means for different kinds of populations and settings. There are guidelines available. There are sample syllabi and internship curricula, just lots of things we encourage you to go and check out so that you don't feel like you have to reinvent the wheel as you're going to think about how to incorporate some of the things you're going to hear from our various guest experts share as far as things that work and don't work when trying to train students and interns in trauma-informed care.
So if you'd like to see some examples of how clinical training programs from several disciplines are actually providing a very systematic approach to trauma-informed care and trauma-specific treatment to prepare the professionals who are going to go out into the field and do this work. Check out the website teachtrauma.com. It has some great examples. They're not the only ones, but they are some wonderful examples, programs that we can all benefit from. And any of the resources that we've talked about that can help you learn more about trauma, children, and families and resilience, they're all in the show notes for this particular episode, and you'll also find them on our website, roadmaptoresilience.org.
So now we're going to dive into the conversations, take a look at the current state of trauma-informed training and hear from several experts and also a current student, graduate student, around some of the gaps and where they might be both in education and in clinical training. So what might it look like to actually weave trauma-informed care into some of the foundational core elements of the ways that we train future clinicians?
So I began nursing school without really a clear plan to specialize in any specific area. I was open to all possibilities and experiences.
This is Yehudis Stokes, a nursing PhD candidate at the University of Ottawa, working collaboratively with the Children's Hospital of Eastern Ontario to plan the implementation and evaluation of a trauma-informed care model there.
From the start, I was keenly aware that mental health care would be an integral component of the care that I would provide in any environment, and that I would be continuously working with, encountering patients, families with histories of trauma, and many currently experiencing trauma through the medical care that they may be receiving. So this was an area that I sought out additional knowledge and training from the beginning of my nursing training. And as time went on, I really saw a gap, I would say, an area of need in our traditional healthcare and mental health care systems. We have well-meaning systems, well-meaning providers that were not always attuned to what the consequences of trauma could look like in healthcare and what could be trauma responses and how to support those individuals and families with these responses rather than providing re-traumatizing experiences. I think that gap related not to individuals' values themselves, but a lack of understanding and of training and of sensitivity in this area. There was a perspective missing. So the patients or families or consumers were right in front of us, and yet it was as if there were often layers and layers of curtains between us, blocking us from really seeing, assessing, and truly understanding the patient from a trauma-informed lens.
Next, we'll hear from Nicole LaPlena, a fourth-year graduate student in the clinical psychology doctoral program at Miami University.
What about as far as mental health training programs? So are there things that the academic programs can be doing or focusing on to prepare their students for working with youth who've experienced trauma? Maybe there are things your program has done really well. Maybe you've heard about it other programs. Like what should these programs be doing?
Yeah, so first and foremost, I think that training programs should have if they have a clinic attached to the program, I think that there should be trauma screening involved in just any sort of intake, child or adult. I think that that's something that is an easy way to be a little bit more trauma informed. But I think just programs making their clinics trauma informed or teaching in a trauma informed way would be helpful, especially like the practicum classes or treatment classes. I know I'm biased because I'm really passionate about trauma. So I think that trauma is always going to be really, really important. But I do think being trauma informed is really important. And I think that programs could definitely be more trauma informed than they currently are.
Yeah. So in terms of like formal classes, but just also weaving that through all aspects of the program, it sounds like.
Yeah. So whether there's a clinic or if there isn't a clinic, just having some sort of acknowledgement in classes beyond just what PTSD is, because I do think a lot of the trauma that I've ended up seeing in clinical work doesn't really map on that neatly onto a PTSD diagnosis. It ends up being a lot more complex, and there's just so much going on that I'm like, oh, this is not what I learned in my, psychopathology course. So anything that could dive a little bit deeper into trauma that maybe if we don't even have the complex PTSD diagnosis in the DSM, still teaching it and teaching what this might look like in kids.
One of the things I've noticed, particularly as an instructor working with students learning about how to provide trauma-informed care, is that sometimes, we talk about concepts and elements of care, but we don't demonstrate. It's really hard for students to know, okay, what does that actually look like in a session? And I think some of Nicole's comments were really helpful to that effect. And I have to say that actually one of the most helpful resources I've used in classes and in supervision is the series that you did, Julian, in collaboration with the National Child Traumatic Stress Network. It's called Critical Moments in Healing Complex Trauma. And this is a free video series available to anyone that's really depicting what is happening in the therapy session. What does it look like in the room to respond to an actual dissociative episode? What does it look like to work with parents at the same time that you're working with kids, to work with youth of different ages, presenting with different types of trauma history, to navigate being a white clinician working with an African-American young man, dealing with a whole host of things in addition to trauma, right? Contextual and systemic barriers. So I just want to give a special shout out to that series for instructors who are working with students that, you want to be able to show what does a session actually look like? What does it mean to intervene in a dissociative episode? I've found that to be an extremely helpful resource.
Thank you, Amanda. I'm glad you mentioned that. I found it to be an incredibly helpful resource because it really is the product of a number of really gifted therapists, and they're therapists from all kinds of backgrounds. We did these sessions live, but with actors as clients, although you would never know that. They're so realistic. And I have to say that it really gave me a lot to think about and some very new approaches to the work that I'm doing. Just watching my colleagues do in the moment the work that's necessary to help children and families heal and move on toward resilience. So I go back and check that out on a fairly regular basis when I want to think through how to handle a particular clinical challenge. It's actually on the Learning Center of the National Child Traumatic Stress Network, which is learn.nctsn.org, and it's in the clinical training resources. And by the way, it's free. All you have to do is just set up an account, and you can access that and many other just incredible resources provided by the National Child Traumatic Stress Network.
And one of the things that you and your colleagues modeled in that series, which I found to be immensely helpful, is how we ask questions and the different ways there are to go about that. So we're going to hear more now from Nicole LaPlena about how important it is to be able to ask some of these questions. Beyond just teaching people about trauma, what does a trauma-informed program look like?
I think it looks like not only teaching about trauma and having your clinic be trauma informed and, teaching how to screen for trauma. But I also think it involves being trauma informed with your own trainees, if that makes sense. So, for example, this pandemic has been really challenging for a lot of students, and any sort of acknowledgement of that. I'm sure a lot of people have lost people in the pandemic, or a spouse or someone close to them has lost jobs, or just a lot of things that can be really stressful. And I think part of being a trauma-informed program involves supporting the mental health of your trainees as well. So I think being trauma-informed can extend to trainees and to clients and classes.
Have you seen that done in a way that respects the boundary between the trainee's personal life and feelings and the supervision and guidance that can involve some support, but isn't therapy?
I've seen it in my program, just with them being more lenient with deadlines in the pandemic, kind of assuming that a lot of us are struggling right now and not pushing us so much, or you didn't get a letter of concern if you were behind on your master's or if you were behind on your comps project. I think that was one good example.
Yeah, little things too. So I had actually seen Professor Andrew Heiss post on Twitter early on in the pandemic, his example of language that he put in his syllabus about learning through a pandemic. And just a lot of these really tangible things demonstrating, to your students that it's important enough to me to actually put in my syllabus that these are the ways I'm willing to be flexible, that I want to understand how you might be impacted differently. And I want to accommodate that, meet you where you are. So I just thought that was a really beautiful and compassionate example example of language he incorporated and also encouraged a lot of us to adopt and modify and embed into our own courses and syllabi. I can't tell you how many students I heard from saying how much they appreciated like seeing that in there very specifically from the get-go, and felt like that was the tone I was then establishing for the semester. So I think just little things like that too.
Yeah, definitely. Even just encouraging trainees to take a couple days off every once in a while. I think especially with different practicum placements, it's almost like you're working at all these different places that have different policies, and it can be kind of challenging to ask for time off. And I think it's helpful too when programs can encourage trainees to take a day off over the holidays or not feel like you need to be overworking so much just to please this practicum site that you're at. And I think that goes back to like just the self-care piece and preventing burnout and making sure that you can still work with kids and adolescents with all types of whatever presenting problem they have, but especially with trauma, which can be kind of hard to mentally carry for other people. I think really the most helpful thing has been when a supervisor validates how challenging the case is or how complex it is, or how many different ways I could have taken the session. I think that's the most helpful, to just really validate, like, I'm a well-established psychologist and I don't really know what I would have done in that situation either. Those sort of moments of humility are really helpful for a supervisee to hear that, oh, you know, once I get my degree and once I'm out in a job, I won't just magically have all the answers. Like sometimes there's just a lot of choice points and cases can be complicated and people are complicated.
Yeah.
And I think what you also highlighted there was a supervisor who notices the choices that you've made and notes where those choices made a lot of sense, even while at the same time acknowledging that nobody has all the answers and there were other choices too. But just the validation, as you said, that seems like that's important along with the humility. Okay, yeah. I have another controversial question. So you don't have to answer this one either. What should clinical supervisors, whether they're in your academic program or at a practicum site, what should they not do?
I love this question.
That's a great question. One thing is supervisors should not dismiss cultural factors when conceptualizing clients or when a trainee is talking to you about the treatment of a client, and not like dismiss or undermine like how important some of those factors might be to what you're seeing in the client. I also think supervisors should not encourage trainees to stay late to finish up paperwork or stay late to see this one extra client just because we need somebody to do it. Or I don't know, I think that they should not encourage overworking, because that is going to lead to burnout and that's going to lead to probably unhealthy work boundaries. And I think really that starts with your supervisor is what I've kind of learned.
Those are great.
How about one other thing that I'm going to add this in, and it may not be relevant because you may never have experienced it. And if so, that's great. What about when a supervisor focuses on what a trainee didn't do or should have done, as opposed to on what they did do and other choices that they might have?
Yeah, I mean, I think we all respond well to just positive reinforcement and positive praise and just pointing out what we're doing well, especially when we're early in our career. I think it can feel like you're not doing many things well, or even just your clinical work. I know I've had the thought sometimes of, oh, I wish this client got like a really good experience, like trauma therapist, but instead they got me. And really, I think that if your supervisor is focusing on the negative or what you didn't do or what could have been done differently, then it's going to kind of reinforce your own negative thinking patterns as an early therapist or somebody in training who's just learning these things. I know I've had one supervisor who really focused on the positive, and almost every supervision meeting, she would point out something that I did well that she really liked when we were watching the tape. And just that gave me enough of just a positive boost for the rest of my day of, oh, wow, maybe I am doing something right. Like, of course, we all have so much more to learn and so much that we could get better at. So I think it is so important to focus on what is going well. And of course, you can address things that are problematic. Those need to be addressed. But some of the things that are a little bit smaller of, oh, well, if I were you, I would have asked this question, or that wording was kind of rough. I think those comments would really hit my self-esteem personally and be kind of discouraging.
Yeah. I think similarly, it was making me think when you asked that, Julian, about examples related to educational training too. I remember having experiences when faculty or mentors would say, "Oh, you've never heard of this person?" or "How can you not know that study?" And it's one of those things like that is just not even meant to shame you, but it makes you really afraid to ask in the future, like, "Oh, wait, can you repeat the name of that person? I've not heard of them." So I think that's actually a big one that a lot of people don't even think about. They just say a passing comment like, "Oh, I can't believe you guys have never heard of this person," or "How can you not know their work?" Right? That actually can have a real chilling effect on people asking the questions that really matter.
This is Dr. Brooks Keisha, an associate professor in the Department of Pediatrics at the University of Utah, and he works clinically at Primary Children's Hospital Center for Safe and Healthy Families. What about pediatricians in training, Brooks?
Mm-hmm.
What's the message for them? What do you think what do you think the field needs to do in order to enable them to become trauma-informed pediatricians?
So when I started medical school 20 years ago, medical school was just starting to make some significant changes to how they structured medical training, and residencies were just starting to make changes, mostly prompted by work hour restrictions. And I don't feel like over the last 20 years, they've stopped changing. It's really if you're kind of into systems and quality improvement and, standardizing processes, it's a little nightmarish, frankly. I mean, we've made so many changes in medical school and residency education over the last 2 decades, after a number of decades where it was still very like, what the training was in the 70s was the training was in the 90s, was the training was in the early 2000s. Like, the knowledge increased, but the process really had stayed very similar. And so we've made so many process changes, it almost makes me hesitant to even answer the question, because then it just requires yet one more change. But what I can say, and what I feel comfortable saying about where do we need to go when it comes to training is really in thinking about, if we want trauma to be a responsibility of pediatricians, I don't think we can do a trauma course for pediatricians. I think we need to figure out how to embed trauma awareness, trauma understanding with everything that they do. I mean, it needs to start with understanding that if a kid is in the ICU for septic shock from whatever got that kid in the ICU, and they come out of the ICU, they need to understand that trauma was a part of that process. And it could be the kid is resilient and there's no need for any intervention, but just that initial awareness that trauma is a piece of that experience, an infectious and cardiovascular process. I think we need to talk about that. I think we need to talk about how trauma is a part of the accidents that occur and bring kids into the ED. I think we need to talk about how, when we're talking about mental health in pediatrics, we really do need to be thinking about a trauma-informed pediatric approach. And that's just different than thinking about, the most common things to diagnose in kids are ADHD, depression, anxiety, and trauma. Like, no. I'd rather them think about, from a trauma-informed perspective, how to go about assessing a child in a pediatric setting. So that's the point. I think, we can't relegate trauma to yet another pathology. It's a life experience, and it's a contextual way to understand the child. And if we're going to be effective, however they decide to educate the next generation of medical students and pediatricians, if we interweave trauma and an understanding of trauma throughout medicine, I think it can actually impact how pediatricians respond to kids. If it just becomes this other kind of mental health diagnoses, which I think is how a lot of pediatricians do initially see it, it's going to get lost by the wayside, and it'll get caught up in everything else, and it'll kind of live its course, and then it'll kind of be done. But how to do that? I think there are folks within the AAP who are really thinking about this and trying to figure out how to interweave trauma-informed pediatrics into everything we do. Heather Forkey and Maura Rizalaji just came out with and Jennifer Griffith, I think. So I think they're the three authors of a new AAP publication on trauma-informed care. And my hope is that every pediatrician reads it, because they really speak to how do we interweave a trauma-informed approach into everything we do. But I think our risk is that we're not going to interweave it, but rather it'll kind of just be this add-on. And if it's an add-on, it's not going to have the sustainability.
You are typically the first responder, if you will, or first person the family is going to go to when, for example, the school says, hey, we think you should get your child checked out for ADHD. A lot of pediatricians not understanding how similarly, a trauma presentation can look to an ADHD presentation, for example, in a school setting, and just not having the ability to tease out what's actually going on here, what's underneath some of these behaviors. So that's a piece I'm just sort of wondering, as you think specifically about training, and when we're training, medical students around things like some of these psychiatric disorders, how do you imagine that training looking like, where we are interweaving these things all throughout the ways they think about kids and evaluate symptoms, to not just relegate it to, oh, well, I guess they're asking me if this child has PTSD or not.
Yeah.
Does that make sense?
No, it makes a ton of sense. And, I think that's that kind of foundational trauma piece, that if you understand trauma early on in your training, so it's taught as part of kind of the core kind of experience of the physiology and the pathophysiology of human being, then layering on top of that, when you do the ADHD kind of component of your training, it makes a lot more sense. If you're all of a sudden introducing the concept of trauma and how it can dysregulate kids and make kids seem like they got a motor inside them and be really reactive to things that seems way out of proportion the way they should. Now you're trying to teach them two cognitive concepts at the same time, and that's probably not going to be as effective. So the way that medical training typically is that there's this understanding of kind of how the body works, and that's kind of the first year of medical school training. And then the second year is, how does the body get sick? So it's the physiology and then the pathophysiology. And we do this well, I think, from a biological developmental perspective, of understanding kind of how does normal development function, and then what are kind of disorders of development, what are when you go off that developmental pathway. I would want to include trauma early on in there, in a way of kind of understanding how the social environment impacts children and how that does in a healthy way, which we frankly don't talk about enough in medicine. Like, how does good parenting and good relationships and good partnerships and all this stuff, this is good for our well-being, it's good for our health. And then take that to the next logical step when you get to the pathophysiology of, well, then how does the social environment negatively impact an individual? And that's where I feel like that trauma piece is so critical. Trauma is not the only piece of those negative or unhelpful or unhealthy social interactions, but it's clearly a key player there. And I think if we were to have it in that construct of healthy and then unhealthy, just like we have, this is how your heart works, and then this is your heart on cholesterol and all these other, and high blood pressure, like if we followed that same process, then when you get to pediatrics and you explain about ADHD, but then also say, now remember what we talked about with the social environment and how that can also cause havoc. One of the ways it can cause havoc is to make that 6-year-old start doing things that we wouldn't expect from a 6-year-old. And so it's important to make sure that as we're working up ADHD, we, just like we make sure there isn't an underlying medical condition, there isn't an underlying social environmental condition, an experience, traumatic stress that's actually driving what we're seeing. That would make sense to any pediatrician, but they need to understand those first steps, both the healthy and then the unhealthy, to then say, okay, because you give them that tool and you say, okay, I know how to do this. I can figure this out. But it requires those building blocks first. Otherwise, we're just asking them to do so many things all at once. It becomes really difficult.
Nursing at its heart is a profession that is dedicated to the holistic care of patients, of families, and of communities. I see nurses as often creating the framework of care. They're the providers that spend the most time being present with the patients on an inpatient unit, for example, and continuously assessing and getting to know the patient's needs. And they also act as the central coordinators often of all the other services that the patient may receive, both in the inpatient setting or outpatient, for example, as a case manager. And so nurses can really have the opportunity to discover who their patients are because of that amount of time that they spend with their patients, and can provide a safe forum for communication, relationship building, and can be advocates for their patients and families in the services and care that they may receive.
So, do you think it's important for nurses to get specialized training related to child trauma?
I think that it's important for nurses to receive training related to child trauma. What I advocate for is that training be an integral part of the nursing curriculum. For the past several years, as long as I've been a graduate student, I've been fortunate to provide a yearly lecture to nursing students on trauma-informed care. And there's been great interest and positive feedback from it. And I would hope that down the road that would become an integral component of nursing training.
Yeah, and I'm just intrigued. I'm thinking about this training you give, and you have such unique perspective, having feet in both worlds. So when you do those trainings, what sorts of things do you notice that nurses or nursing students already know about this, and what sort of things about child trauma are totally new to them?
Mhm. I think everyone is familiar with the concept of trauma, and everyone has experienced difficult experiences in their life to an extent that they can understand the challenges that difficult experiences present. What I hear a lot from those that attend my presentation on trauma-informed care is really beginning to understand the link between the experiences that people have had and the responses that they see in people, and better understanding how those link together, and that their reactions are not random or by choice, but really linking them back to how it actually makes a lot of sense when seen in a paradigm of trauma-informed care. So a lot of what I do is educating about trauma and about how trauma affects our brain development, how trauma affects our functioning, and the reactions that we are most likely to see with those with histories of trauma. And that seems to create a light bulb for many people in just acknowledging that, this actually makes a lot of sense. All of these discrete reactions that we couldn't make sense of, we can now put into a picture that is valid and that makes sense in a trauma-informed lens.
So we've heard from Brooks, who's a pediatrician, and Yehudis, who is a nursing professional, and they really remind us that the areas in which we need to have a trauma-informed approach are not just in the mental health arena. They certainly are there, but they also extend to the medical, nursing, and all the allied health disciplines, and embedding that kind of trauma-informed approach where we think about the children and families who are our patients or our clients, and we think about what they've experienced in their lives and how that's affected them, and how we can help them to regain a sense of safety and to recover from a sense of fear or threat that is exactly what happens when children and families experience trauma. Having that deeply embedded in the medical and nursing training programs, and let's take it beyond that, in programs for legal professionals. And we'll hear in this series from several colleagues who represent the legal professions, in social work, in marriage and family therapy. It really runs across the entire gamut of training and potential ways in which we can prepare professionals to provide services that actually foster resilience for children and families who've experienced trauma.
I appreciated how they both also gave really concrete examples of how programs and systems and healthcare organizations can start to embed these types of principles into training programs. I think that can feel really overwhelming when you are a mentor or supervisor, or you run one of these training programs, around, does that have to be kind of a complete overhaul of our program or the way that we train students? And I appreciated hearing from both Brooks and Yehudis about specific ways to do that it can actually start with small changes and then lead up to philosophical and sort of orientation type changes that you were talking about. So I think it's great that we started by focusing on how trauma-informed care can be embedded into actual training programs.
Great point, Amanda. It doesn't require a complete overhaul. It requires the introduction of some core concepts and some strategies for working with kids and families who've experienced trauma. And that can be done very efficiently. So now let's take a look at the other side of the training equation, and that's the students, the professionals in training. Here's some advice from our experts who know exactly what it's like to still be in the role of the trainee. And we're all learning throughout our careers, but I think it's most essential that we pay attention to what students who are just beginning their careers, what do they tell us about what's important in providing a trauma-informed approach to their training?
I'm just sort of thinking about, I don't know any student that has ever felt ready, right, or fully prepared to jump into these practicum or internship or clinical contexts. I, even after all these years, still feel nervous, when meeting with somebody new. So I'm sort of curious about what advice you might give to other students in that position about to start their first clinical training experience with a potentially traumatized population. What thoughts do you have there for your fellow students or trainees?
So my advice would be to go back to building a solid relationship before you ask too personal of questions. I think that was one mistake that I made at times, was just jumping right into intake questions when some families are going to need a little bit more rapport there before they even start to share some of that information. Some other advice would just be, talk to your supervisor, really. If you feel like something kind of landed flat, or if you feel like, you said something and it wasn't very well received, or maybe how you asked the question was kind of invasive to the family or to the child. So talk to your supervisor about that and see what sort of input they have. Be kind to yourself in the process of working with kids who are traumatized. It's okay if you become overwhelmed by a child's life history and just everything that they've been through. Kind of being kind to yourself. If this is something you're not used to and you're kind of lost with what to do, and just kind of seeking out guidance from your supervisor or whatever colleagues you have available to you. And just reading things about trauma for fun. I think that's something that I do because I love the topic. So just finding a book. I know memoirs are really fun to me. It's not so academic. I don't necessarily pull up academic articles for fun, but, of reading a memoir about trauma, or, I love Trauma and Recovery is a great book too, but just kind of reading books about trauma to make yourself feel more prepared or feel like you have more knowledge, because you probably will have to read a lot beyond what you learned in your class. I don't know if any programs have mandatory trauma classes. I think that would be really cool, but I know mine doesn't. So a lot of what you're going to learn is just reading on your own time. And get a therapist. I love my therapist. I think that I even came into this program thinking that therapy is I shouldn't need therapy if I'm going to be a therapist. And then, by the end of year one, that's a part of my self-care. So I think getting a therapist too, and it helps you understand as well just how hard it is to find a therapist, and to find one that you really like and that you really vibe with, and that you feel like your therapeutic relationship is fun, or whatever you're looking for. And dealing with the financial piece and seeing if you can find a free therapist through your program or something like that. I think that having a therapist is a great idea, especially if you want to work with traumatized populations. I think one piece of advice also to future clinicians, especially if you're child focused, is to not be afraid of working with parents or other family members. I think that has been a huge key to better serving my clients, is working more closely with the families. You'll have some difficult conversations with parents and family members, and that's okay. Maybe they are not big fans of mental health treatment, and their kid just kind of ended up receiving services, and you'll have some tough conversations, but by far the most helpful thing has been working with families more closely and kind of taking that family systems perspective, because the child really is not out living on their own, in their own little bubble. They're living within this family and within this structure. So that's been really, really helpful. And giving the parents that psychoeducation about trauma as well. I know I just told a mom the other week about physiological responses to trauma and how a child's anxiety could be coming from living in community violence and being around gun violence. And to me, it seems so obvious because I'm in this field too deep at this point. But for her, that was the first time she had heard that. And so also remembering that, you know a lot more about mental health and trauma and how the body responds, how the mind can respond than, the typical person and possibly your client. So even just going back to some basic psychoeducation and just working with the family.
That's a great reminder.
Yeah,
How do
thank
you, and correct me if I'm wrong, you do not have kids, right?
No, I don't.
So that's why I wanted to ask, because this is something I get from my students all the time. How do you deal with when you're talking about that intimidation of working with families, which I know a lot of people have in the beginning, especially? How do you deal with that age-old question of, well, do you have kids? How do you know how to help us?
Yeah, I mean, those are always awkward moments. It's always uncomfortable. And I use that as just like a sign that something's off in this therapeutic relationship moment right now. Like our rapport maybe isn't what I thought it was. And it just kind of signals to me that I need to take a step back because they feel like I'm not getting them or that I'm too different from them. Working at my previous placement, working with a lot of Black families and in juvenile justice, they really saw me as a symbol for people who oppress Black people and arrest Black people and keep them in the system. And I had a family member really say, like, why should we tell you anything? Like, you don't get it. It's similar to if you don't have kids, how could you get it? You look too young to have kids. Like, how could you know what it's like to have a kid that's, has conduct disorder or whatever it is? And just being humble and saying like, yeah, I really don't know what that's like. All I know is I want to help support you through this and, offering compassion in that moment. Again, then I probably wouldn't badger them with more questions at that point and really let them kind of guide the next probably few minutes of conversation. But those moments definitely come up and they're definitely uncomfortable. But looking back too, every time it happens, you learn how to respond to it in a different way and learn like what this is kind of symbolizing. So like I said, maybe feeling like I just couldn't understand them or that this time together is pointless because what could I possibly know? So I think it's helpful when families are vocal. I appreciate that now more than a very passive family who just does nothing and just kind of, okay, we'll like do this worksheet, but they're really not feeling it and don't express it, So
I love what you're saying also, that you don't have to, and none of us should claim to be an expert where we're not. And none of us are experts about the lives of any of our clients because they are the experts. They know their lives. We don't. But what we do know is we know some things, and you said this earlier, about trauma and stress that most people don't know. And maybe that's something that we bring to the encounter, along with a willingness to really get to know the clients, including their family. That's a wonderful combination. So there is something we know that not everybody knows, and there's also things that we know that we can learn, but they're the teacher and we're the learner.
Yeah, definitely. Oh, I was just going to say one last bit of information of like a tip or advice for a new clinician working with traumatized populations, kids, adolescents, families, is to not shove a treatment down someone's throat and to really kind of check the temperature and see how they're receiving the information, see if the modality that you were planning to use is really going to work for this family, or if they need to take a step back. Really being flexible with that is the most important thing that I've learned, and not, just not forcing a kid or a family to use, this one's CBT sheet, or we have to do cognitive restructuring today, but perhaps listening more to what the client seems to want to talk about. I know that's always a hard balance of, not letting the client just ramble about random things the whole session and still working towards goals. Solicit feedback too. I think that that's been helpful.
And sometimes with that, I think that's really key, because the other tricky part of that is if your supervisor is the one really encouraging you to do that treatment and you're feeling caught in the middle of this, like, my instincts say, like, I don't think that's maybe where this family is right now or what's going to make sense, but I have a supervisor telling me here's how I need to do it. And so I think that you can sometimes be stuck there and need to practice advocating in different contexts, or saying, I get why that would really make sense. Here's why I think with this particular family that might not make sense just yet. Or could we try this other thing instead? Like, don't be afraid to listen to your gut and advocate a bit with your supervisor, or just explain your concerns.
Yeah, definitely.
Now here is Dr. Archana Basu, a clinical psychologist and instructor in the Division of Child and Adolescent Psychiatry at Massachusetts General Hospital and Harvard Medical School.
What do you, as a teacher, as a supervisor, as a clinical trainer, what do you emphasize that you really want your trainees to take away from their training, in addition to respect for evidence-based practices and good ethics and good boundaries? What do you particularly want them to take away that will help them be the best possible help for parents and children?
I would say that, well, I think they're sort of related, but they're two separate things. So the first thing I would say is we really have to think about the unique needs of families and communities. And when we work with children, we're really working, as I've said, I think multiple times, it's about supporting the people and systems that support the kids. And that includes parents, caregivers, and the broader community. I work in a department of psychiatry, and, most places, the initial assessment appropriately begins with understanding symptoms and behaviors and the challenges that, bring a family to us in the first place. But we also know that, we are not just a sum total of our symptoms and problems, and that these problems also differ based on the communities we come from. So I think one of the things that I would say is community-led approaches and understanding the unique needs of communities is absolutely critical. We knew about this before the pandemic, and especially true now, which is that under-resourced communities, racial and ethnic minorities, subgroups such as immigrants who don't often have the same access to healthcare, they are all particularly affected in this pandemic. And this was, as I said, true even before the pandemic. But what it looks like for each community and family is pretty different. And so even as we're thinking about a child and the caregivers, our parents, we also need to think about the broader context in which they live, work, play. So I think thinking about broader assessments, which, I think are often called social determinants of health, and what it means in terms of, the local community. That is something that I try to prioritize, and I think is sometimes missed in our more symptom-focused approach. Relatedly, I would say, yes, there are community-specific needs. There are also community-specific or highly culturally specific, strengths and protective factors. And again, this is something that we have, I hope, as part of our broader training, always been the case. But now in the pandemic, when we're all talking about how do we build resilience, what promotes coping, we really have to think about, integrating a strength-based approach that often, not uncommonly in my experience, also importantly builds on a culturally sort of informed and respectful sort of approach. So thinking about what are the cultural influences and community strengths are also really, really key. The last thing I would say is that although your question asked about training for mental health professionals, I would say that, there is no health without mental health. And a big part of what I want, mental health trainees to take away is that they have something to offer to their colleagues who are not in mental health, but are health professionals as well. So I think recognizing that mental health curriculum, particularly trauma-informed ones, can actually be very important and are in fact critical to the training for all types of health professionals, even if they're not focused on mental health, is actually really important for most people, their primary care provider or pediatrician or their OBGYN might be the first person that is actually screening for, asking about, or the first safe person that they can even talk to about some of their concerns. So I guess I would say that there's a piece of training and I think advocacy for all of us, which is that we need mental health awareness and training outside of mental health kind of professions themselves.
No, I just appreciate you all including pediatricians in the conversation. We care for the same kiddos, but for whatever reason, the way that medicine has evolved over the last century has arbitrarily kind of separated us in a way that, it's taken a lot of effort to get the integration that we currently have, and we have a long way to go. And so I think having these conversations and talking across silos is so critical. The kids that keep the pediatricians up at night are most often the kids who are going to be seen in mental health settings.
That's right.
And so the more that we can be talking and problem solving together, I think the more we can undo some of the faulty design from 100 years ago in terms of how medicine and healthcare and mental health was intended to be set up originally.
Oh, I agree.
Here's to eliminating the Cartesian split.
Yeah.
That's right. That's right. And they're never going to get to us until they've already gone through you. Like, I think that's what's so frustrating is, so if we don't work together and have this ongoing dialogue, we can't.
So here we are.
Oh,
We're
that's
doing
right.
it.
Exactly. Thank you,
so
Brooks.
much
This was
for doing
amazing. As we close out our conversation, we wanted to connect you with a few additional resources. So we've mentioned quite a few organizations and websites and resources throughout this episode, which again, we'll be sure to link in our show notes and on our website, roadmaptoresilience.org. We wanted to give you a little bit more specificity in terms of how a trauma-informed care program might work. So now you're going to hear from Dr. David Corwin, a professor at the University of Utah Pediatrics Department and the immediate past president of the American Professional Society on the Abuse of Children.
I'm also interested in improving the training. I think that should be their training. And in the future, hopefully more and more, especially pediatricians, but all of the other primary care healthcare providers, that's one of the huge gifts that the state of California is giving to the world through this ACEs Aware effort, is all of the educational materials, the webinars like we created with the California ACEs Academy. We now have 11 webinars online that professionals throughout the country could watch and receive professional continuing education credit for, no cost. But then how do we get the word out? How do we make it something that providers want to do and will go do?
So I hope this episode has been helpful to all of you who are in training, who are providing training, who are teaching students who are at the beginning of their career, or continuing education providers for professionals in practice. We all can participate in this really wonderful opportunity to embed and infuse a trauma-informed perspective in the training and the teaching that we do. And when we do that, we're really preparing professionals from all disciplines to be able to provide a trauma-informed approach in the services that they provide and as they foster resilience with children and families.
And I think it's a great reminder too that we can all keep learning, no matter how long we've been in this field or been providing trauma-informed care. We still have a lot to learn, and a lot of the time we can be learning about what we can do better from our students. So I think it's great for us all to remember that there's much we can do to continue evolving as trauma-informed care professionals and to keep listening to what our students are asking for. Many thanks to our guests in this episode, Dr. Archana Basu, Dr. David Corwin, Dr. Brooks Keisha, Nicole LaPlena, and Yehudis Stokes.
Visit roadmaptoresilience.org to learn more about our guest experts, access additional videos and resources, or send us a message.
If this episode piqued your interest, we'd love for you to leave a 5-star review on Apple Podcasts and let us know what you think. And if you imagine this episode would resonate with a colleague or friend, please share it.
Roadmap to Resilience is a collaboration between Pandemic Parenting and the University of Connecticut School of Medicine, with special thanks to the Interorganizational Child Trauma Task Force.
Roadmap to Resilience is produced by my co-hosts, Dr. Julian Ford, myself, Dr. Amanda Zelahusky, along with Carmen Vincent and Victoria Bruick. Many thanks to Jennifer Valentine for her strategic support, and to the teams at Pandemic Parenting and the Center for the Treatment of Developmental Trauma Disorders for providing promotional support.
We'd also like to thank the Substance Abuse and Mental Health Services Administration's National Child Traumatic Stress Network for their financial support of this project.
Thank you for joining us in supporting children in need of a roadmap to resilience.